also welcome Dr. P.C. Manoria, our Chief Moderator from Bhopal, past President of CSI and other organizations, a great name in field of cardiology in country.
Dr. Padma, both acute myocardial infarction and strokes are caused by thrombus formation in the culprit artery, and the treatment of both these emergencies are the lytic therapy or endovascular intervention. The lytic therapy and angioplasty is widely utilized for treatment of AMI in our country, even at small places. But lytic therapy for stroke and endovascular therapy is highly underutilized. So what else can be done so that it becomes more popular? And is it that a DM neurologist is required to initiate thrombolysis, or a trained physician can also proceed with thrombolysis?
Thank you, sir. And you really hit the nail on the head. This is exactly what we took forward, and we told the government of India, it is there now in their NPCDCS program. You don't need a neurologist to thrombolyze. No. Strokes have to be managed by a physician who's manning the emergency at that level. So therefore, we made it free, available at district hospitals, and the stroke care is delivered by the physician. So the net has to increase, the net has to expand and include physicians into the ambit of delivery of acute stroke care. Now, mechanical thrombectomy, on the other hand, is a high-end and high-intensive and high training is required. And there we've got now the National Boards of Examination. We have the NEET program now to include other specialties, and not just the radiologist, not the neuroradiologist. We also got the general radiology, neurology, and neurosurgeons to be trained for the neurointervention. And therefore, the corpus or the resource people who will be able to deliver the mechanical thrombectomy will also be increased in the country. So well said, sir. There are efforts now, and I think even the government of India has realized that neurologists are not going to manage strokes alone. It has.
Dr. Bhatia, what is the status of stroke in young in the Indian context, and how does it differ from stroke in the elderly? Dr. Bhatia, please.
Thank you, sir, for the question. I think we are a country of young people, and reasonably so. We've had a epidemiological transition over a period of time, and I think our mean age of stroke in most of the studies is somewhere between 50 and 60, average about 55, 56, which is much lower than what is in the West, which is almost in the 70s. The typical stroke in young, which used to be defined as non-conventional risk factors below 45 years of age or 40 years of age, is also seen a transition where we're getting many young people, both intracerebral hemorrhage and ischemic stroke, with significant conventional risk factors, which have either not been noted by the family or they have been ignored. So I think we do see a lot of stroke in young, and if you really want to characterize stroke in young, I think the true stroke in young for non-conventional is truly probably the age below 35 or 30, and I think anyone above age of 40 is probably turning more into a conventional risk factors. So compared to the West, I think the true stroke in young may be ones with not the usual conventional risk factors, because their mean ages are very different than reported in the West. But I guess with the changing epidemiology of risk factors worldwide, we're probably ending up seeing more of conventional risk factors now, and a small proportion which will be with the non-conventional risk factors. That's my perception about the whole thing.
The other issue is hypertension is a common risk factor of a stroke, but most of the stroke occur in patients with mild hypertension and not in patients with severe hypertension. What are your comments on this?
Well, sir, hypertension is hypertension, and I would probably slightly disagree with the fact that mild hypertension or moderate hypertension or severe hypertension should be really segregated when it comes to stroke. I think as a risk factor, it stands out clearly in almost all epidemiological studies worldwide that hypertension is the #1 risk factor, both in the West and in India. And intracerebral hemorrhage, of course, we know that it may happen due to triggers, and the triggers are on the top of what people already have in the baseline. And I think I reiterated during my ISA oration also, and I think there was something mentioned that there is a plan to take hypertension to almost all households by giving more education. I think hypertension is one which is grossly ignored. and grossly underdiagnosed. And for me, hypertension is hypertension irrespective of how do we characterize. Once we characterize, we must do as aggressive risk factor control as we would do for any hypertensive.
In fact, sir,
I will.
stroke. Oh, okay. Dr. Vijay, please.
No. I just wanted to echo what Rohit is telling, that hypertension is hypertension. That we are trying to reduce the level of blood pressure control as much as we can, but the common understanding is very, very clear. If you reduce the blood pressure of a person 9 millimeters mercury systolic and 4 millimeters mercury diastolic from the baseline, even if he is normotensive, you reduce his risk of stroke by 44%. This is for secondary prevention. So, it is not that mild hypertension will not benefit or severe hypertension will not benefit. Every hypertension will benefit from treatment of hypertension, reduce the blood pressure level, whatever means you can. And don't worry, mild hypertension, severe hypertension, this is just a continuum, because hypertension is something like blood pressure is never continuous. It keeps fluctuating for every one of us. So, that's a different thing, whether the hypertension is coming with end organ damage, then it's a contributing factor. Then, if the renal failure is coming in, then it complicates hypertension further. So that's a totally different issue. But otherwise, hypertension has to be treated as aggressively as possible. And even with normotensive, they should be careful about their blood pressure control. Even they should aim for a lower number.
Dr. Sharma, all of us know.
Right. So actually, so
yes, please.
yeah. So, but actually, if for residents, we always say this, that hypertension is a risk factor for a hemorrhagic stroke, for an ischemic stroke, for an embolic event, for a bleed after thrombolysis, for a bleed even otherwise, for a recurrence of stroke, and for a stroke outcome. For everything, it is. In fact, when you say the risk factor for stroke, say number 1 hypertension, number 2 hypertension, number 3 hypertension, and then say number 4, okay, diabetes, cardiac, you're smoking, and what have you. So that remains.
Dr. Sharma, all of us know atherosclerosis is a systemic disease, and polyvascular disease is not uncommon. And polyvascular disease is associated with heightened cardiovascular risk. So in your clinical practice, a patient is admitted with stroke, do you screen for coronary artery disease or peripheral arterial disease? What is your strategy?
Okay, so everybody gets screened for coronary artery disease in one way or the other. ECG is the first investigation as soon as patient arrives into the hospital. That we don't want to miss, because there is a fair portion of patients. So it's said like this, that about in tertiary care centers, about 10% patients who come to the hospital with a stroke, within first week, they develop some kind of coronary event. And 10% of patients who come to the hospital in the real age group coming with acute MI, they develop a stroke. So this is a common risk factor, common treatment, common primary prevention, common secondary prevention. The same is for the peripheral vascular disease. Peripheral vascular disease, it is a part of workup for stroke. Sometimes people even select the antiplatelet therapies, that if there is a concomitant peripheral vascular disease, people try to use a combination of aspirin plus diparacetamol more than what people use in other conditions. Same is clopidogrel is much preferred drug if there is a concomitant ischemic heart disease. So they go hand in hand. You have one vascular disease, you are definitely going to have another vascular disease. Same is, carotid studies is an inherent part of workup for stroke patients. And we know it that if we see a thickened intima media thickness, it is more associated with coronary artery disease as compared to stroke. So, there is no demarcation. Everybody gets screened for all these conditions, definitely, yes.
Dr. Yes.
So even kidney is also getting involved.
Yeah, true, yeah.
Dr. Bhatia, Dr. Padma already alluded on the wake-up stroke. What I would like to know is, how do you determine in a simplistic way the time of onset of stroke if it occurs during sleep, and how do you decide whether the patient is in the time window? Sophisticated investigations may not be available. Dr. Bhatia, please.
Yeah. From the historical perspective, I think there are few nuances which, if a person is staying with his family, they could probably pick up, especially if they see, for example, they're not certain, but they find him in the bed, but they can actually look around and see whether the patient has gone to the kitchen or he's had some change in his, the attire of the room, or he is moved around in the house, any indirect evidences to support that he was probably fine after he slept. Otherwise, typically, if you see a patient who's got a wake-up stroke and the family really doesn't know because they would have last seen him at 11 or 11:30 in the night, it will be very difficult from the historical aspects. Now, in the simple imaging paradigms, if you see a scan and you presume that patient has last seen at 11 p.m. and he's come to your hospital at say 7 a.m. in the morning, and you do a CT scan and the CT scan looks extraordinarily normal, and patient has a clinical stroke which is moderate to significant, that's an indirect sign to say that patient's ischemia may have been recent if you're looking at a CT scan. For example, if you have an availability of an MR scan, then people have used an MR diffusion and a flare scan. It is said that flare changes would take generally between 4 to 5 hours to develop. So if you have a diffusion weighted MRI showing an finding and your flare imaging is normal, then you can potentially consider that the patient's stroke window is within the last 4.5 hours, probably from the onset or maybe lesser than that. Of course, these have fallacies and they're not 100% sensitive and specific, but these are methods to do that. If you're at an advanced imaging center where you still believe in wake-up stroke and a patient has a large vessel occlusion on a CT angio, we have very clear 2 trials to demonstrate that if you have a perfusion mismatch by using a CT perfusion, and patient has, even if the last seen normal is within 24 hours, but you have a moderate to severe stroke, a large vessel occlusion, and a mismatch, these are the patients to be taken up for endovascular thrombectomy. We've had trials to show thrombolysis works up to 8.5 to 9 hours using these typical MR paradigms or perfusion paradigms. But I'm not certain that in clinical practice, people are still very comfortable thrombolizing because we've still not reached a point of thrombolizing even 4.5 hours patients. So we have a long way to go before people are going to be comfortable thrombolizing wake-up strokes. But a good CT and NIHS mismatch is a good indirect way of looking at it. And of course, if you have imaging facilities and MR and CT perfusion.
Dr. Padma, stroke during PCI for AMI is uncommon and occurs in say 0.2 or 0.4%. But whenever it occurs, it creates a great setback for all of us. So I would like you to enlighten on the emergency treatment of such strokes and what should be the tips for treatment.
Right, sir. Thank you for that question. In fact, we keep dealing with this 2 occasions. One is when on the table strokes in a cardiac cath lab. One is when they're doing the PCI. The other is even when they're trying to do the valvotomies and things like that in a patient with rheumatic heart disease. We've had these 2 occasions, and on the table, the advantage is that the sheath is in place. So there you are, straight away you can go ahead. What we do is we just wheel out, do a plain CT scan because there's a lot of heparin which is already going on there, and you need to definitely rule out a bleed. And it's not there, then go directly and do an intra-arterial thrombolysis. A lot of times people have used the newer intra-arterial things. We no longer use the alteplase or so. They've done even the GP2B3 inhibitors, which people use routinely, the interventionalists. But we can give intra-arterial alteplase. And the intra-arterial, if it's not there, it's a large vessel that there's a cardioembolic event, then go ahead and do mechanical. So the advantage there is that the sheath is in place. So it is far simpler in terms of a time management, and you're there in the cath lab. So the logistics as well is that the cath lab, the DSA lab, and the plain CT scan are just 5 to 10 steps away. So from the cath lab, they can be wheeled into CT. If there is a lab with a CT there, that's great. But in our practical setting, this is what we do. We wheel into plain CT, rule out a bleed, go back to the lab, and through the sheath, either do intra-arterial, large vessel, do a mechanical, and a large number of them do extremely well. So on table, during intervention and an embolic event, this can be done, sir. And sometimes, in fact, I've also seen a spasm, and we don't see anything, and while the CT is being done, they actually start improving. And there, the perfusion and looking at the blood pressure will become very important. Again, it's a holistic management that you do. If there is a clot, take it out or lyse it, or also take concomitantly the hemodynamic aspect of it. Dr. Vijay also wants to say.
No. I just wanted to add another situation. Patient comes to the emergency with acute stroke, And the first investigation, which is ECG, which shows the hyperacute changes of anterior wall or say inferior wall MI. So now the question is, do you want to still give TPA and thrombolize for two events, stroke as well as a coronary event? People usually don't do this. People say that save heart first. Heart kills, brain not commonly kills, but makes you paralyzed only. So you will still survive. So treat the heart first, save the life first. So this is not uncommon situation in tertiary care centers.
And the worst thing, sir, if I may add just a 30 seconds more, is a real life scenario which we had actually seen is, in fact, a fellow surgeon, an orthopedician to be exact, who had a stroke, thrombolized, and was then after thrombolysis, because echo is not mandatory into the pre-thrombolysis criteria, and was being shifted to a stroke unit. On the way they did an echo and they found that there was an LV thrombus, and he was shifted back. And then after thrombolysis, you can't give him heparin according to guidelines again, but this person did embolize and had a post-circulation stroke subsequently, unfortunately. So these things, that is one of the causes of early neurological deterioration, one of the things called as END, that is within the first 48 hours after thrombolysis. So these caveats are always there, so that, and heart and brain are so intricately, connected. And Rohit, in fact, had an heart and brain conference in 2000. And when did you do, Rohit? Sometime back. So there's so much happening between heart and brain. I fully agree with you, Manoria sir, that we always test for coronaries, we always test for peripheral arteries, and now even kidneys, because they all have the common vessels. And yes, besides the artery block, we also have a whole host of electrocardiographic issues, the arrhythmic issues which also happen. We have the Takotsubo syndrome. We have so much happening whenever there's an acute event, whether it's an MI or a stroke.
Sometimes when a patient of AMI is thrombolized, or after PCI, when an echo is done, it shows a clot usually at the apex. He is on anticoagulants. So do you ever think of removing this clot, or what is your strategy?
No. So actually, the moment there is an acute stroke, the most cardiac interventionalists, I'm sorry to say that, especially a CTV surgeon, then they run a mile. So whenever there is an acute event, I think especially when there is an acute brain event, most of the interventions take a back seat. They wait for a couple of weeks before, because the anesthetist doesn't give you a clearance at all. And it depends upon how large is the ischemic event, how much is the damage, and so on and so forth. So those are, again, so there are no broad guidelines. We have been, I think it requires an individualistic approach a lot, and weigh risk and benefit of a lot of factors. We need to do that balancing act, walk on the tightrope, but it can be done, and we've done. In fact, you have it, sir. You have a stuck valve who've been thrombolized. You have this prosthetic valves which don't move. You give, the thrombolytic agent, and they have a bleed in the brain. So you're always between devil and deep sea. We've had cerebellar bleed when a prosthetic valve was lysed because it was struck. And we actually had to do CT scan every single day and look at the resolution of the cerebellar bleed, because we had to get back the anticoagulation. Otherwise, the prosthetic valve would go. And the CTVS guys said, we can't do we can't do a surgery because he's had an acute stroke. And the anesthetist was not giving a clearance as well. So I think these devil and deep sea situations happen. In that, we take an individualistic approach. That guy did pretty well.
Dr. Sharma, do you routinely do transcranial Doppler in managing strokes with lytic therapy?
Most of the thrombolysis, when we do it. But with the advent of more and more mechanical thrombectomies, because we are rushing, if the machine is available, we always put on the head and we always monitor whether we have recanalized or not. It saves actually one more investigation.
What is the difference in outcome following lytic therapy or thrombectomy, mechanical?
So mechanical thrombectomy is only for those patients who have a large vessel occlusion, where you can remove the thrombus. If you don't see a large vessel occlusion, then TPA still stays as the gold standard and the only therapy which is available. Otherwise, the outcomes depend on how bad is the stroke. Usually, they are determined by the level or the severity of the stroke. But number need to treat, if you are taking patients for mechanical thrombectomy, is 2.5 or 3. That every 2.5 or 3 patients you thrombolize. you get one excellent outcome. TPA is dependent on time. You know, you saw that slide that if you are thrombolizing within 90 minutes, then you are having a number you to treat of 3.5. It doubles when you are reaching 180 minutes. It triples when you are reaching, it becomes 14. It actually becomes 4 times higher if you are thrombolizing by 270 minutes. So TPA related outcomes, they are all related to how fast you can initiate thrombolysis.
Dr. Bhatia, a patient has developed a brachiofacial paralysis of 2 hours duration, and luckily he comes to the hospital. His CT is normal. Can he be thrombolized straight off?
Of course. We have to thrombolize him. I mean, the history, and actually, sir, in stroke, I would always reiterate, everything goes parallel. Everything goes parallel. And everything goes parallel. And I think the history, wheeling to the patient, the CT room, deciding, giving the thrombolytic bolus through needle, I think everything goes parallel. If your scan is good, you've taken the history, no immediate contraindications, I think we are good to go.
But the problem faced sometimes is that suppose the patient which has come for this paralytic stroke, he is a TIA, he recovers on its own. So how did you decide it was a TIA or a stroke with CT normal patient is a paralytic symptom?
The whole confusion is that we have gone through the textbooks of definitions in the past. We've gone with the definitions in the past where people have said stroke and TIA up to 24 hours. And unfortunately or fortunately, we know that most of the TIAs would last in minutes. So if a patient is coming to me with 2 hours of evidence, 2 hours of onset of a focal neurological deficit and my clinical diagnosis stroke, there is no reason and there is no absolute wisdom in waiting and presuming that this is going to be a TIA and is going to recover in 2 hours. This is a stroke, sir, and it is a stroke. Anyone who's not recovered in the emergency room is a stroke, irrespective of whether this would have been a TI in this pathophysiological basis. So we don't really use that. If the patient has completely recovered by the time he has reached the hospital, that's a true TI. Or he's recovering, that's a recovering stroke. But for us, any deficit in the emergency is a stroke.
In fact, sir, I would go on to say that, Rohit is absolutely right. Most TIs barely last 5 minutes. You have more than 15 minutes of a thing sitting there, it's no longer a TIA. And you also have imaging now which says that TI also, the so-called TIA have substrates. But more importantly, just like you have an unstable angina, we have recurrent TIAs. These guys go, come back, go, come back. There's something called a capsular warning syndrome, which you see in small vessel issues and deep down in the brain. So just like unstable angina, you have recurrent TIs happening. I'm not waiting. If I don't even have a vessel imaging with me there, of course I will do a vessel imaging immediately. But if I'm in a center where I just have a plain CT, I have no provision for CT angio, I have recurrent TIAs, I don't wait, I thrombolize. And we've done that in the past.
Madam, what is the time lag between the onset of ischemic stroke and appearance on CT findings?
Okay, so the CT findings take longer. So unless you're thinking about those guys, we have absolutely no collaterals, everything is going to die there. You may have a development of a large hypodensity pretty soon, but even that is not going to happen in the first 3 hours or 4.5 hours. The time window we are looking at IV thrombolysis. So in a plain CT scan, then the things will start to be really obvious 24 hours later, unless it is a huge large artery gone and no collaterals. Even then, it's not going to be evident in the first 3 hours. But there are subtle findings on the CT scan, which we call as early ischemic changes, which as strokeologists and for DM neurologists we teach. But please remember, for physicians, when we looked out at the WhatsApp model, we said there should be nothing dark and nothing white. It's like a monkey-proof model. Everything white is bleed. Everything dark as such is a developed ischemic process. In both those situations, you're not intervening. We had to give this kind of an SOPs when we're going peripherally at a district hospital level and training, just MD physicians to go ahead and thrombolize. So you need to have that very, very, those SOPs where you're not having the chance of probability of a bleed. But there's always a chance, but that's how we go. So CT changes won't appear early.
The other problem is sometimes we are faced with a lacunar infarct. So how often CT is normal in a lacunar infarct and patient faced with paralytic symptoms, CT normal, will you be able to differentiate between a lacunar infarct and the large vessel ischemic infarct?
So the lacoon is not a problem for me because a lacoon can be completely silent, but a lacoon can cause a massive infarct, like if it is there in the internal capsule. So the massive, innocent, massive deficit if it is in the internal capsule. But then there are, of course, neurological ways of looking at whether it is likely to be small vessel or large vessel. But for all practical purposes, lacoons are included into the entire subtypes which can be thrombolized. So we have evidence to say that across the board, whether it is large, small, cardioembolic lacoons, all of them are included into the benefits of undergoing IV thrombolysis. So that should not matter to me. But when you go into really in-depth and more into the stroke pathology and how the outcomes are and what has caused those things, those nuances will be different. But when we are giving a take-home message, we say that don't bother. If the CT is normal, you have a deficit, it's not hypoglycemia, your BP is controlled, go ahead, thrombolize.
Dr. Bhatia, sometimes we face a situation where there's a disparity between the clinical finding and CT findings. That is, the patient has more neurological deficit but less finding on CT. What does it mean and what are its implications?
It actually means he has a bad stroke, sir, and he's very early in the window. And fortunately, he's living on collaterals, and we are not actually he's truly at a zone where he will infarct or develop more worse ischemia if we don't open the vessel or we don't thrombolize. So the vessel occlusion could be obvious on a CT. It may not be obvious on a CT, but it may be more obvious. So it's a great scenario if you have a CT and IHS mismatch, because that's a patient who should be treated very aggressively.
And if you want to look at penumbra, what is the imaging modality which is the best?
Sir, I would say
to...
practically for a stroke patient, I would strongly suggest that it should be CT perfusion, because that is, it's very well validated now over the period of time. We've learned more about CT perfusion. MR is difficult to do in an acute setting. MR perfusion has not been done too much, even in most of the EBT trials. So I would strongly recommend a CT perfusion. And if you are in a center which has already its own set paradigms and the radiologists are using your standard CT scanner, which is either a 68 slice or a 128 slice, and they do a perfusion within their own software, and they will have to spend some more time. But if you're in a center which uses an automated software like Rapid and others, that will automatically give you the thresholds, and you'll be pretty much clear within a matter of less than a minute or two that this patient has a significant mismatch.
Dr. Sharma, is MR ever utilized before lytic therapy?
No, I can tell you my center, we see about 1,000 new strokes every year. We thrombolize plus, the endovascular treatment in nearly 350. So that comes to around 30-35% of the strokes. And MRI is done probably once in 3 years before doing any of these treatments. It's all CT based, CT perfusion based. MRI, I told you, 1 in 3 or 4 years. So this is almost never done because it's very difficult to do it. You don't want to sedate your patients to do an MRI. These patients are restless. MRI is not in the emergency room. You have to wheel the patient to an MRI room. And MRI room after office hours is always a luxury. So it's multiple, the reasons why we don't believe in MRI, why we don't utilize MRI. But, I have utilized probably 5 years ago, one MRI for thrombolizing a patient.
But the thing is, sir, Professor Vijay Sharma is absolutely right. And we are also more CT based, as Rohit said. Like Rohit and me are in the same stroke team in our center. But there are situations where MR is used, and in our center we use it. We use it for our, sometimes for the mismatch. Sometimes we use that than CT, and more of for the stroke mimics as well. Sometimes for posterior circulation. There are specific situations where we use, and we are a little more, again, it's different clinical practice settings for us. We have probably a little more access to the MR, which is geographically closer into our practice. So as Dr. Vijay said, it depends upon your practice settings. Like where Rohit has trained, Calgary is also is CT based entire thing. I don't think they also do MRI, isn't it, Rohit?
Yeah, but I think, as you rightly said, there are nuances where there is a marked uncertainty that it may be a mimic and you still are within the window and you would spend another 10-15 minutes extra to get some idea whether it's truly a stroke or not, especially in very young people, or where you have concern it could be a conversion or something. And as Dr. Padma said, posterior circulation stroke sometimes, especially people come in with just pure isolated vertigo and or with sudden onset dizziness, because you want to be slightly more sure before you want to thrombolize, even though, as rightly said, even if you thrombolize mimics, the risk of having an ICH is not significantly different than a stroke. But still, nevertheless, I think MR may have its own value in scenarios.
No, there are some centers in Europe who are doing primary thrombolysis based on MRI.
Yeah.
They have MRI scanner in the emergency. Instead of wheeling the patient into CT scanner, they wheel the patient on MRI, and they say that we can do it within 15 minutes. So why to take the patient for CT scan, which is a poor modality of imaging comparatively? So it depends on definitely on your availability and how you are trained.
Dr. Sharma, what are common stroke mimics and what message would you like to give physicians to pick up these stroke mimics?
Okay, so stroke mimics, the commonest one which creates problems is the post-ictal paralysis. So this is one of the commonest ones because this occurs in people with previous epilepsy, previous stroke, scar epilepsies, and then nobody has witnessed their seizure, and then they come with weakness of one side. So this is one of the commonest mimics. The other ones, hemiplegic migraines, conversion reactions. So all these conditions, they come as stroke mimics. The saying was this, that if you are still having within a time, and then you are still confused that are you seeing a stroke mimic or you are seeing a stroke, and this is a stroke which is at least of moderate severity, it's measurable on the NIH stroke scale, people still like to thrombolize them rather than leaving them alone, unless there are very strong evidences, very strong proofs that this is more closely like a mimic. We did one of a retrospective surveys for 6 years, that how many patients were ultimately turned out as stroke mimics. We found that there were about 2% or 3% patients, they came out as stroke mimics at the end of the day. But we were happy that there was not even a single bleed in those patients. It's not that giving TPA in patients with mimics, it said that the bleeding risks are there with TPA, but not as much as you give for stroke. It's still probably 0.5% to 1% bleeding risk definitely is there. So everybody starts becoming careful once you see some red flags, which are not typically fitting into a stroke. So this is the commonest one which creates problem actually is a post-ictal paralysis. Your conversion reactions, neurologists usually pick up them, very nicely. Hemiplegic migraines, and these are the two which we are always worried.
Dr. Padma, what is the sensitivity of picking up a vertebrovascular stroke by CT compared to a carotid stroke? And how are the results of thrombolysis in vertebrovascular stroke?
So the thrombolysis part would be the same because, clearly posterior circulation per se being taken out has not been really done. But we do have the registry of basics, which we are looking at the basilar strokes and see that their outcome probably is different from that of a carotid strokes per se. But largely, if you have to look at it, then the interventions are the same, whether it is posterior circulation or it is anti-circulation. Said that though, CT versus MR scores sky high compared to CT scan in picking up. In fact, we had one patient who did not come to us in the window period. He did go to another center within the window period, missed totally, and thought to have peripheral vertigo or something that kind, and the patient was admitted with us, and they did an MR also and missed it. And we repeated an MR because our clinical suspicion was extremely high and it was a tiny little lateral medullary syndrome. So it does. So the clinical suspicion, you're correlating your anatomical substrate, you look for it. The posterior circulation strokes are much better picked up on an MR versus CT. But when you're looking at interventions, the principles are the same, whether it is anterior or posterior. Depends upon what artery and the ischemic substrate, and also the question of what is a salvageable tissue. It's still there. Earlier, they used to say that posterior circulation was much more amenable to a longer interval for intervention. That ischemic tolerance concept has been debated, but even the original TIA definition was different, but now it is common. So it is not that the posterior circulation guys routinely will have a longer interval to be picked up for interventions. So the timelines are the same for both.
Dr. Sangram, how much time more you want to finish?
Yeah, a few questions on the chat box we can take and close. Okay.
I'll ask 2 questions and then the chat box. Madam, what if the patient of a hemorrhagic stroke develops DVT on 3rd or 4th day? How do you manage?
So this is a great question, and it has always been debated upon. And there were, in fact, as recent as just a couple of years ago, the trials went on as to whether they can be managed prophylaxis as well as management using DVT pumps versus giving them heparin and what have you. But it seems now that the DVT pumps were not doing great. However, that is routinely done for us, but they do develop a thrombosis, then we do anticoagulate. And what is the anticoagulation we give? We give low molecular weight heparin. How much do we give? We start once a day and then we hike it up and we monitor the status of the patient and whether there would be bleed. In fact, there is now evidence to say that even in hemorrhagic stroke, if you give the management, both prophylaxis as well as treatment with a low molecular weight heparin, it's not going to greatly enhance the kind of a bleed in the brain. So therefore, it's again a tightrope walk, but that is what we need to do because venous sinus thrombosis itself is a huge thing. It can go up to, especially a lot of them have central lines. They develop these venous thrombosis in the upper limbs and this DVT goes into PTE. It's a problem. We have to manage it.
Last question to Dr. Bhatia. What is the recurrence rate after the first stroke?
Good question, sir. So one of the very recent papers which came in NEJM very recently, just I think within the last few months, talks about an approximate recurrence rate of close to about 5%. So I think it's roughly about anything from 5% on an average of risk of recurrence, but it will strongly depend on what is the underlying etiology and also the kind of risk factors which are prevalent in our community. So I would say an average rate is close to about 5%.
There's one question in the chat box. Role of thrombolytics in cardioembolic stroke. Dr. Bhatia or anybody or Dr. Padma or Dr. Sharma.
I would say that when it comes to a management of acute stroke, pragmatically we would treat them as we would treat any stroke. So if you see a posterior circulation stroke and you are certain that you're dealing with a posterior circulation, the question is about
cardiomembolic stroke.
Sir, it doesn't
matter.
matter.
Thrombolytic in cardiomembolic strokes.
It may be any ischemic stroke, go ahead with thrombolysis. Cardioembolism is an etiology and the patient has had a stroke. So the aim would be to treat him similarly that you would treat in any etiology, whether it is cardioembolic, local thromboembolic, intracranial or extracranial vessel to vessel embolism. The difference would be the prevention mechanism secondarily, not the treatment of acute stroke. So irrespective, whatever be the underlying etiology, the treatment of acute stroke will not differ at all. It will be the secondary prevention which will differ, and the difference will be between antiplatelets or anticoagulation. And obviously if it's a cardioembolic, it will be anticoagulation.
Dr. Padma, another question is, what are the community-based checklists available for prevention of stroke in India?
So the community-based checklist would be the same as a tertiary care checklist, would be the same checklist wherever. Whatever is preventing heart attack will prevent stroke as well as dementia and also prevent probably the kidney disease. So these big three is a common risk factors and common prevention. The only way where we differ would be to subtype a stroke, and that is possible even at a district level hospital which is dealing with communities. So if you're looking at a prevention at the community, look at your risk factors. Everybody after the age of 40 years, get your blood pressure checked, and if you have a family history of a stroke or an MI, be more careful. Don't stop antihypertensive just because the BP is normal. BP is a silent killer, and all this all of us know. That look at risk factors and good lifestyle, and don't smoke and don't drink alcohol. As a neurologist, I'll never recommend alcohol. There I'll differ with you, sir. Manoria, sir, you cardiologist said red wine. To me, red, purple, yellow, I don't care. No wine, no alcohol. Brain doesn't know when to stop. So therefore, that's community. But I think even in a district hospital, subtype the stroke because your prevention will depend upon what kind of a mechanism it is.
The other question is how to manage a posterior circulation ischemic stroke like pontine.
So manage it the way you would manage any stroke. If pontine or thalamic or subcortical or frontal or occipital, doesn't matter. What matters is timely management of the stroke, irrespective of how it will be.
The other question is what antiplatelets you utilize in ischemic stroke? Single, double? If double, what double?
Sir, for a standard of care, if you have a TIA or a minor stroke, some paradigms changed after emergence of 2 big trials. For the first 21 days on an average, we would treat with dual antiplatelets, but this is limited to TIAs and minor strokes. For people beyond that period, patients will be treated with a single antiplatelet, typically aspirin. The dose could be anything between 75 and 150, depending on what you're more comfortable with. And there are some people who would prefer clopidogrel. There is no much difference, but I guess looking at the cost, availability, aspirin remains the workhorse for secondary stroke prevention. There are scenarios like intracranial atherosclerotic disease or extracranial moderate to significant extracranial carotid disease where you are pushed to treat for longer times, at least for 3 months. And then, of course, if you're doing a revascularization, patient will require either aspirin if you're endarterectomized, or if you're undergone a stenting angioplasty, you would require long-term dual antiplatelets and then transition to single antiplatelets. The answer whether long-term dual antiplatelets is safer or better for intracranial atherosclerotic disease remains very unanswered. And hopefully, over a period of time with some newer studies, we will have that. An individualized decision for management with dual antiplatelets remains very specific to individual patients' scenario and severity. And we have patients who have very severe ICAD where they have high risk of having a stroke again, where we have maintained them much longer on dual antiplatelets. So I guess it is the monitoring and the choice which will be individualized for patients.
Now, what is that second antiplatelet? You said DAPT, aspirin plus what?
Aspirin plus clopidogrel, very typically. And in scenarios where clopidogrel has not been effective for some reason, or patient has a mutation for a specific clopidogrel resistance gene, then you can probably consider cilastazole, which seems to be a reasonable alternative. There are people who also use aspirin plus dipyridamole, but it all depends on a given scenario what you would prefer. But the standard treatment is aspirin plus clopidogrel.
And just recently, very, very recently, it was, I think in the month of June 2020, ticagrelor was approved, aspirin plus ticagrelor only for 1 month in minor strokes and major TIAs, high-risk TIAs. So that has also, been approved, But we don't have luxury like cardiologists, too many antiplatelet drugs. Basically, we have aspirin and clopidogrel.
Bye-bye to aspirin.
But we follow
bye-bye to aspirin most of the times.
So we have the luxury, but we are very cautious about the brains bleeding.
The last question to Dr. Padma, what is the best advice for a TIA patient? He recovers, usually ignores. So what is the best advice?
Don't ignore, prevent another stroke. A stroke is a stroke is a stroke. TIA, minor stroke, mild stroke, don't even think about it. Stroke is a stroke. So prevent another stroke. Go to the doctor, look at the prevention, control your risk factors, take an antiplatelet, prevent another stroke, and get on to a good lifestyle.
No,
Have
TIA,
good sleep.
TIA
and you
has
should
to
end
be
this webinar, sir. 9 o'clock.
Yeah.
Eat in time and go to sleep in time.
No, TIA has to be treated like an emergency.
Absolutely, sir.
Yeah.
Even if
Over
it is
to Dr. Sangram.
Yeah, we are closing and signing out. A last take-home message from Padma Madam and any post-COVID, your experience COVID with TIAs or a stroke.
So COVID has been a great teacher so far. So we've seen that COVID can cause strokes and COVID can present as strokes, and COVID in this scenario, because of multitude of other reasons, strokes can be part of the comorbidities and the elderly who come as strokes. So all three scenarios of young strokes, with no risk factors. COVID presenting as strokes, all varieties of strokes, whether it's venous or arterial or in an arterial, both thrombotic as well as bleeds, and developing strokes during the hospital stay in young differently and in elderly with comorbid differently. So various reasons, and we've seen this. More importantly, we've also developed protocols to save time as well as keep everybody safe. So the green corridors and the protocols what are being developed as a code specific for management of stroke in a COVID scenario. So in the emergency, how to manage a person coming with stroke who's not COVID, or you don't know he's COVID positive, with protection to both the caregivers, the patients, as well as the physicians and the nurses and the stroke team. All this has been developed and it is ongoing. It is now well oiled and we've developed a lot of, but more importantly, what we've seen is the brain affliction with COVID. And as part of the long COVID and the huge neurocognitive and neuropsychiatric manifestations which may develop, including degenerations, which are now of current research interest, there are large multicentric trials ongoing in the world with more than 60 countries included, collecting data on COVID survivors and what's going to happen to their brains over a period of next 6 months, 1 year to 3 years, using both biomarkers as well as clinical data. Because there is a suspicion that they may be developing degenerative diseases and dementia, cognition, and neuropsychiatric. But I think it's a huge, it's a minefield out there. We're still learning every day, and now even the vaccines have gone into the same fray. So yes, sir, the take home is we have one brain. Keep safe. This is the only organ where God has given a natural helmet, which is a skull. So therefore, keep it active, keep safe, stay healthy.
Thank you, madam.